Today what I'm going to do is give you a number of case studies, I think, in your terminology, for how we're able to use genomics or personalised strategies to predict the outcome of interventions. So I'm going to talk about exercise and also healthy aging. The same methods have been used in cancer prognosis routinely. They're much less used in other areas of medicine, but they're directly applicable to everything I heard this morning. So hopefully everyone will get something from this talk. So the talk will be a quick question about whether exercise is actually even good for you or not. Let's start being controversial. Then I'm going to talk you through some of our methodologies for building and validating predictors of outcome. And then I'm going to, in the second half of the talk, give you some of our most recent data on a diagnostic for healthy aging in humans. So we're bombarded, not just by the BBC News website, but probably especially by the BBC website in recent years, about discoveries which will revolutionise medicine almost every day. And this goes for how walking will reduce your chance of developing breast cancer, to how exercise and good nutrition, whatever good nutrition happens to be, will improve your longevity. And here's an example. And what Fergus Walsh is referring to here is the fact that in a lifestyle-related study, some molecular measurements were made on the telomere length of some white blood cells in this particular study. And really what you have to ask yourself is, fair enough, maybe the exercise did change this particular biochemical or molecular marker, but is that marker predictive of anything? So, of course, in the case of telomere length, we know that it's not predictive of longevity or good health into old age in humans. It's a marker of replicative senescence in a petri dish. So these messages get misconstrued and mispresented in the media all the time, but we also do it ourselves within the mainstream areas of biomedical science. So here's the BMJ. Again, a meta-analysis published very recently and covered extensively by the media. So in this particular study, some analysis, a meta-analysis, was trying to claim that exercise was just as effective as many pharmacological interventions in terms of preventing, for example, stroke. The question is, what's correlative and what is actually causal? So, for example, all of the exercise data relied in this particular review was correlative epidemiology. It wasn't the size effect of an intervention. And in particular, when you talk about exercise, we have very little data where exercise alone has been controlled and changed to look at clinical outcomes. So I think that many people, including myself, have held the belief for a long time that we empirically and absolutely know that doing more physical activity for an individual is good for them. And the question is really, how strong is the science behind that claim? So let's look at a couple of intervention studies. Again, the warning here is that these are lifestyle interventions. So these are exercise, advice on diet, advice on behavioral traits like please don't smoke. But they are two of the most clear-cut studies in the medical literature. So we have the Look Ahead trial, which was terminated last year, three years before the end of funding, because, as I'll show you, and then some meta-analysis, some follow-up analysis from the Finnish diabetes prevention study. So there's been two very successful diabetes prevention studies that show 10 years on, exercise reduces the amount of type 2 diabetes that you see in the population being studied. So for sure, both in terms of Look Ahead, the Finnish study, and also the American equivalent, the intervention reduced diabetes, improved the body mass statistics, so reduced fatness. And so you would argue that the biomarkers were changed, and in fact, in terms of the diabetes effects, it was about 48 to 50% reduction. So it's very clear this lifestyle advice worked for type 2 diabetes. If you look at the impact on, for example, heart attack, angina, or stroke in these particular studies, there was absolutely no benefit 10 years on. So at the point where the intervention group showed a reduction in diabetes, showed a reduction in body fat, and were physically more fit when measured in the laboratory, it didn't translate to major changes in cardiovascular endpoints. So when we talk about what exercise will do in terms of a public health message, we have to be very clear about what evidence we've got. So the question is, why did this happen? It could be that lifestyle modification doesn't deliver the macrovascular benefits that we tell the public. That's one option. If that's the case, then it means our health economics are wrong, because the modulating type 2 diabetes won't translate into impacting on the cardiovascular disease burden, and of course that'll keep many people here in plenty of work. But really the question is this because of a lack of causality, or is it because of the way we intervened? For sure what we did was we applied a one-size-fits-all in those 2 intervention studies. So did we give too much exercise to some people, too little? And this is really where my research is focusing on. So if we look at supervised, 100% supervised intervention training studies, what we see, and we've known for nearly 20 years now, is that you get a large range in responsiveness in terms of fitness, strength, or metabolic profile. So if we look at the left here, this is the gain in aerobic capacity that you see from baseline across about 500 individuals. You see negligible or even a decline in some individuals. This is test-retest variation, and then of course you see some people who make large gains. The correlation coefficient between baseline fitness and gain there is 0.004. It's nothing. This is gains in lean body mass, again, resistance training. Very important if we're thinking about how we combat frailty. Again, you have about 25% of your subject population will not gain lean mass. And that's, again, despite being provided a tailored resistance training program. And when it comes to blood pressure or metabolic endpoints, this is the profile from an intravenous glucose tolerance test. And again, no, actually, that's the fasting data. The IVGT is exactly the same, but essentially you have people who substantially improve after 20 weeks of endurance training, and those that actually demonstrate a poorer profile. So the question is, how much exercise should you as an individual do in order to make the best gains, make sure that you get a fitness gain, or you get an improvement in insulin sensitivity. Just one slide just to show you that even with the so-called magic high-intensity training, you still get a distribution in terms of fitness responses. So this is doing, what would that be, 4 minutes in total, 3 times a week of high-intensity training. And here you see the distribution of gains in aerobic fitness, from high gainers to people who show a very significant and robust decline in their oxygen transfer capacity. These people are actually demonstrating the same peak heart rate, their hemoglobin is fine, their ventilation is the same as before, their actual workload and the time that they can continue the test has increased, but their oxygen transfer from mouth to mitochondria has actually declined. You might think, well, maybe this is just mistakes, variation, but this is the test-retest variation in this cohort, and this is the relationship between baseline and change. So for sure there are non-responders and adverse responders, but probably the clearest data or evidence that these people exist is that we can measure genotype and RNA signatures that predict in advance who they might be. So I'm going to comment on how you might build a predictor or a diagnostic. And really what I'm going back to here is the central dogma that you'd all have encountered probably in first or second year undergraduate biochemistry, or perhaps even physiology these days. So what we have is we have this concept that we have a lot of information stored at the level of DNA. It passes briefly through this RNA intermediate molecule, so you've got transcription. The RNA is translated to protein, and protein interacts with metabolite, controls, and vice versa in the form of post-translational modification, and this ultimately affects your physiology or dictates your physiology. And of course, we're particularly interested in physiological or clinical variation. So it's very obvious that you could measure things at each of these steps to try and predict or understand the physiology or the clinical variation. So most popular, most common, the thing that makes the news most frequently is DNA sequencing, GWAS studies. And so what you do is you try and hunt for a variant that relates to your clinical variation. In many cases, this is not appropriate because you typically need thousands and thousands of subjects, and you need another set of thousands and thousands of subjects to replicate your findings. Otherwise, you've just got a one-off correlation. For many patient subcategories, that won't be possible. You'll never have enough patients. You could, of course, focus on protein and metabolites. Metabolomics is looking very promising, but it requires large mass spec facilities. It's tricky technically to do, and there's a long way to go. Proteomics is something that people really focus on, protein biomarkers, and most people get taught that a protein biomarker is probably something that would be far better, for example, than an RNA biomarker, because surely it's the protein that does the function in the cell. This is really a bit of a misnomer, not just because RNA functions as an RNA molecule, independent of being translated into a protein, but principally because the abundance of a protein can't tell you very much about its function. You think about the number of factors that change the activity of a protein, the number of post-translational modifications. It pretty much means that that abundance value is capturing very little knowledge about where the protein is in the cell and also what its activity is. So, surprise, surprise, my bias is to focus on the RNA variation. RNA is typically is in one of two places in the cell. It's either being transcribed in the nucleus and kicked out to lead to some aspect of RNAi or protein formation, or it's been degraded. So it's a much simpler system, if you like. We also have very good tools for very sensitively and specifically measuring the abundance of our RNA, and so the diagnostic side of things is far superior to proteomics. So what I'll now talk you through is a few examples of us using RNA to look at and predict outcomes from interventions. So this is our standard clinical physiology protocol. We study people at baseline. We make multiple physiological and biochemical measures. We take muscle biopsies, blood samples, psychological state, etc., etc. We supervise people, and in this case, this was a study which I set up at Karolinska, so everyone did what they were told, everyone turned up for training, it was all very dutiful, and we got 100% compliance. Typically, 90% plus would be on average for our intervention studies. In this case, we're looking at what might predict the changes in aerobic capacity. We have very good test-retest at baseline. And the question is, can we pick out those non-responders purely from the baseline RNA profile? And again, just to re-emphasize here, baseline fitness does not relate to improvements in fitness in sedentary people, recreational athletes, and any other population we've ever looked at. So this is a snapshot of what you can achieve with this type of study. So on the left there, what you see is a heat map plot of the genes that we end up selecting. Now, I'll go through in a couple of slides' time how we select genes from the 50,000 transcripts that we measure in each biopsy. But in this case, we've settled on 29 genes. There's the gene names on the right-hand side there. To be honest, it doesn't matter what the gene names are or what the potential function is. All we are interested in here is how good this expression signature for each individual relates to the gain in aerobic capacity. And so what we do is we generate a signature that allows us to pick out high from low responders or high, medium, and low. We then take that signature and we validate it in an independent cohort. And I think everyone in this room will understand the importance of that. In this particular study, what we also went on and did was we mapped some of the transcript variants to genetic variants in a larger intervention study, the Heritage trial. But basically, this was a case study or an example of how you could simply use an RNA signature and go across 3 independent studies and pick out who was going to be the non-responder for aerobic training. And this was carried out in young sedentaries, middle-aged sedentaries with, who were overweight, and also some recreational younger people, and the same signature picks out the non-responders in each case. So what about muscle growth and aging and frailty? Well, most of you will be aware or encountered aspects of cachexia, for example, in patients, but we also have this concern of age-related loss in muscle mass and function, which leads to loss of mobility, independence, and really a severe impact on quality of life. If you look at the epidemiology, what you see is this is total body potassium, but it's a surrogate of lean mass. You see this age-related decade-by-decade decline, but you notice the variability. So for a given age bin here, 70, you've got a large variation in lean mass retention. So the question that we've really got now is, well, the people who retain lean mass, are those high responders to their daily activity? Their muscles able to actually respond and maintain size? Or contrary to that, are the non-responders the people at risk? In order to ask these sorts of questions in longitudinal trials, what you need is a diagnostic in the first place. You can wait 30, 40 years, but most of us want a publication slightly faster than that. So if we look at the outcome of our intervention studies, this is one example. We've now got about 4, so we're beginning to build the classification model to predict the non-responders. But here we've got middle-aged older men and older men and women, 20 weeks of resistance exercise training, very classic training paradigm that any sort of physio or personal trainer would give you. Progressive adjustments to try and optimize the training, all of these concepts that we believe in, which are probably not true. And this is the distribution of lean mass gains that you get by quartile. So what we have here is we have people who are very good at putting on lean mass versus a quarter of the group that simply cannot increase their lean mass tissue by DEXA. Their macronutrient contents were exactly the same between the high and the low gainers. They had the same percentage carbohydrate, protein, and fat. So what we've begun to do with this particular phenotype is probe some of the potential biomarkers. On the left here is just a principal component analysis, and all it's basically saying is that any of the protein biomarkers that we knew from the literature didn't in any way associate with the change in lean mass over there on the left. What we were able to do is pick out about 500 or so RNAs which seem to correlate with lean mass gain in humans. Now this is really just the start. This just shows you that the muscle itself is behaving in a different manner between those that grow muscle and those that don't grow muscle. Prediction is a different matter, and really what I'll do is give you a different example about prediction now, and I'll talk you through a healthy aging predictor. But we now have 4 independent data sets to address this topic, so hopefully within the next 12 months we'll have a predictor of lean mass growth in humans, and that could be interesting because it could also be a surrogate for cardiac growth. We certainly find a lot of overlap between exercise responsive gene programs and cardio and functional hypertrophy in cardiac tissue. So this is the paradigm, the methodology that we use. So on the left, we've got a very simple starting point. We've got a group of healthy young people. In this case, these are Swedes. So we have about 20 healthy young people, 20 healthy older people. So again, in Sweden, 65 years of age is about the same as, say 35, 40 in Glasgow. These people are pretty healthy, and as you'll hear, we went on to study these well past 90 years of age, where they still have good function. So what we do here is we build what's called a classification model, and in this case, what we're doing is looking for nearest neighbor. It's nearest KNN, nearest neighbor analysis. So we take an unknown sample and we put it into the expression space here, and basically ask which genes or which probe sets allow us to determine whether a sample is old or young. And what we're doing here is just building up a simple model. The computer algorithm and the machine learning methodology we use is on the right here, and basically, in a nutshell, one of the key things that we do is we loop members of the the training data set in and out so that we don't bias our data set. The other key thing to remember is that once you've built a model, that clinical data set is now useless. You should then throw it away and only try and validate your model in an independent cohort. So here's an example of the performance of the classifier that we built. And this is all human muscle tissue. So we started off with the training data set in Sweden. And we got pulled out a set of transcripts that were about individually 90% accurate at determining the difference between young and old. And that's kind of a no-brainer because we start off with two very divergent groups. The next thing that we do, however, is we take that gene list, that 146, which is about 0.7% of what you can detect in the muscle, and we validate it in a blinded manner in multiple independent data sets. And what we've ended up demonstrating is we have something that's about 93% accurate for tissue age. Now, this is all in skeletal muscle. And so one of the first questions we then have to say with this type of classification methodology is, does it work in other organs? So we've pulled down data sets from NCBI. These are brain bank data sets, so the tissue is not collected nearly as neatly as our muscle data. There's delays in the tissue freezing, et cetera, et cetera. And we've profiled the genes between young and old post-mortem samples in different brain regions and been able to demonstrate that this muscle-derived signature also classifies brain age to a very high degree. And so it's very clear that what we have here in terms of brain, muscle, we've went on to look at other tissues, that this is a multi-tissue molecular program that seems to differentiate between healthy and young and old people. The question is, what can you do with it? Is it of any use? This is just demonstrated. This is the ROC curve, so 1 over specificity and sensitivity. Little point there is that the markers for healthy aging in humans don't overlap at all with any of the literature that we've seen in worms, flies, or mice, which are all very short-lived species. And so I think there's a word of warning there that it's best to start with human clinical data. Okay, so we've got a classifier. We've validated it across 7 independent cohorts. Question is, can we do anything with it? And so there's a study that's been running in Uppsala in Sweden for about 50 years. And we had nice snap frozen biopsies from around 1990. And we looked at the 146 marker genes in these baseline samples. And then we were able to relate that to the clinical data over the following 20 years. It's a relatively small study. For this type of analysis, 108 subjects, but there are very, very few cohorts where we have a healthy tissue. There's maybe some histopath type tissues going way back, but very rarely do people archive and collect healthy blood or muscle or other tissue types. So the subjects were ranked at baseline. They're all 69. They're all physically active by UK standards. They're all pretty healthy. Subjects are ranked first, meaning they had a very low medium gene score. This means that they failed to switch on what we see changing between young and older healthy people. And of course, subject ranked 108th had a high median gene score and strongly activated what we've called a healthy aging program. So what does the gene score tell us at baseline? Well, the lower the gene score at 69, the greater the loss or decline in renal function we noticed 12 years on. Perhaps more strikingly, particularly given the size of the cohort, was that the higher the gene score at 69 meant that over the following 20 years there was a much reduced risk of death. And this reached significance again, despite the fact that we have a relatively small cohort. So what this is an example of a diagnostic that we've validated through multiple independent data sets and then applied in a quantitative manner, and it seems to give us some rather interesting outcomes. Just one comment here is the methodology that we've used to look at this age-related endpoint could be applied to any of your areas of cardiology that you're interested in. Aging is a very complex phenotype, as everyone would agree, so is exercise responses. We're not really that interested in what genes are driving the signature, because really that's futile game in some people's minds. Really what you're interested in is how reproducible the diagnostic is. So in summary, exercise, a one-size-fits-all approach to training people doesn't work. We know that for sure. We've got some data emerging now that maybe we're asking some to do too much and others to do too little. But it's very clear that when we apply that one-size-fits-all approach to a public health type strategy, we're not getting the cardiovascular benefits that we expected. The other thing to mention is that RNA-based diagnostics can be used to track outcomes over a couple of decades. Perhaps something I didn't mention very clearly was that this RNA age diagnostic is not modulated by diet, exercise, moderate weight loss, moderate cachexia, or type 2 diabetes. So it's a signature that's independent of the sort of classic confounders. And I hope that this gives you some confidence that RNA biomarkers would be a pretty good and powerful tool for studying your outbred human populations. And thanks for your attention.